Well, so what's our challenge with CAR T cells? Forget the cost; that's a huge challenge. But one of the biggest challenges is availability. You decide a patient needs CAR T cells. You have to collect them. You have to manufacture cells. You have to get them back, and that's anywhere from a 17-day to 28-day process. And we know from the published studies that there are people who never get there, okay? Now, frequently, they're not included in the efficacy analyses because the efficacy analyses are restricted to the patients who are infused, but they reduce your ability based on intention to treat to improve outcomes. So what happens if, theoretically, we have a CAR T cell that we could just give to people without having to wait for manufacturing? Oh, AUTO3. And that's exactly what the advantage is of a product like this. Now, of course, it's got to work, and it has to be safe. The development, we need to make sure that we're not getting graft versus host disease. Because of the construct, you don't get HLA recognition, so that's very important. So the safety profile actually looks pretty good. In fact, there was no grade 3/4 cytokine release syndrome seen in the Alexander trial. Now, this is a tiny trial. This is a dose-finding study, so a little bit, early to, declare victory. Many of the patients were treated at very low dose levels, and that may have been one of the reasons why we didn't see a lot of toxicity. We also didn't see very much ICANS or the neurotoxicity associated with CAR T cells, which is favorable. We did see some preliminary efficacy. Even at very low cell doses, we saw complete response rates. So it really does appear to be promising. Now, in this study, they threw in Pembro to help persistence of the T cells and to keep them from becoming non-reactive and senescent. Whether the Pembro was important here, we don't know, but certainly this combination has initial promise, and we have obviously are eagerly awaiting border scale trials.